Hemolytic transfusion reaction. After learning, students should be able to understand the pathophysiology of the reactions, explain causes and effects of the events, select an appropriate laboratory investigations to help diagnosis and monitoring of medical treatments, and the most important thing is to manage and select the best blood components for patients to prevent the reaction that may occur again. Transfusion reactions can be classified into two main groups, acute and delayed, depending on the onset of the reaction. Both groups are also divided into immune and non-immune mediated based on causes. Immune-mediated reaction means that patients produce autoantibodies specific to red blood cells, white blood cells, platelets, or plasma, while the non-immune-mediated reactions are caused by other factors. Hemolytic transfusion reaction is classified as immune-mediated acute transfusion reaction. Typical signs and symptoms of acute hemolytic transfusion reaction include fever with or without chill, respiratory distress such as wheezing, cough, dyspnea, and cyanosis, blood pressure changes, especially hypotension. Other signs and symptoms of acute hemolytic transfusion reaction are disturbance in gastrointestinal tract such as abdominal pain, nausea, vomit, or diarrhea, pain of chest, flank, back, abdomen, or pain at the infusion site, skin changes including urticaria with may itch, rash, pruritus, flushing, localized edema or angioedema, renal failure presenting in oliguria, anuria, or red urine, abnormal bleeding, which may be observed as blood oozing at the infusion site or surgical lesions. Signs and symptoms of acute hemolytic transfusion reaction resulting from the activation of the complement pathway, cytokine system, coagulation pathway, together with shock and renal failure. Activation of the complement pathway causes intravascular hemolysis. In this slide, patient with autoantibodies was transfused with donor having specific antigen. So, donor cell will be agglutinated by intravascular autoantibodies and complement bound. Compression of the complement cascade causes hemolysis, which can be observed in increased free hemoglobin together with decreased haptoglobin in the fresh serum sample obtained within 1 hour after onset of the reaction. Some red blood cells containing complement components will be destroyed by phagocytic cells in the RE system, which cause extravascular hemolysis and can be observed in increased bilirubin. Complement activation pathway produce two important mediators, C3A and C5A. They can cause anaphylactic reactions, so they are called anaphylactosins or anaphylaxins. What will be happen after complement activation? First, hemolysis, which can be both intra and extravascular, as mentioned in the previous slide. Second, and is the most important one, is anaphylaxis or anaphylactic reaction, which presents different patterns of signs and symptoms depends on variety of cells that express C3A or C5A receptors. They are first, blood cells, including platelets, mononuclear cells, mast cells, and leukocytes. Second, endothelial cells. And lastly, smooth muscle cells that support the blood circulatory system, respiratory system, and GI tract. What will happen to blood cells after binding to anaphylactocin? First, mononuclear cells. After binding, mononuclear cells will be activated and induced to release two groups of cytokines. The first group is inflammatory cytokines that can cause inflammation. They are TNF-alpha, IL-1, and IL-6. The second group is chemoattractant proteins, including mp4, mcp1, and IL-8. These molecules can induce expression of antigen molecule receptors on the membrane of leukocytes. This event causes accumulation of leukocytes at the infusion site. Secondly, platelets. After binding, degranulation occurs to release inflammatory cytokines, coagulant proteins, and mediators, including granulose enzymes, nitric oxide, leukotriene, oxygen radicals, and chymin. Coagulant proteins will activate extrinsic coagulation pathway. Thirdly, leukocytes. After binding, degranulation occurs to release granule enzymes. Lastly, mast cells. After binding, degranulation occurs to release granule enzymes as well as other mediators, especially histamines, that can cause allergic reaction. Degranulation of the mast cells can be occur in two events. Firstly, immunologic activation or type 1 hypersensitivity. It occurs when antigen and IgE antibody complex was bound through IgE receptor on the cell membrane. Secondly, non-immunologic activation occurs when other ligands, including C5a, bind onto the cell membrane through its specific receptors. These two events lead to degranulation and release of mediators, including histamine, that can cause allergic reaction. So, allergic reaction occurs in HTR will be called mimic allergy. Allergic reaction in acute hemolytic transfusion reaction includes urticaria, which may itch, pruritus, rash, localized edema, and flushing. What will happen after binding of anaphylactocin to endothelial cells? There are two events occur. First, release of coagulant proteins that leads to activation of extrinsic coagulation pathway. Second, express adhesion molecules resulting to leukocyte accumulation at the infusion site. Binding of anaphylactocin causes smooth muscle cells contraction. The contraction of smooth muscle cells supporting blood vessel causes vasodilation, which leads to hypotension. In respiratory tract, bronchoconstriction is occur, which results in wheezing, cough, hypoxemia, and cyanosis. While in GI tract, smooth muscle cell contraction leads to peristalsis and causes nausea, vomiting, diarrhea, and abdominal pain. Smooth muscle cell contraction causes different signs and symptoms in various organs. In respiratory tract, contraction causes bronchoconstriction, resulting in wheezing, cough, dyspnea, chest pain, or other signs of respiratory distress. In GI tract, peristalsis is induced, leading to abdominal pain, nausea, vomit, or diarrhea. For cardiovascular system, dilation of blood vessel occurs, resulting in hypotension. Extrinsic and intrinsic coagulation pathways are both activated in HTR. Tissue factors released from endothelial cells and platelets after binding to antigen-antibody complex or anaphylactocin can activate factor 7, which initiates the extrinsic pathway. In another way, antigen-antibody complex directly activate factor 12, which then starts intrinsic pathway. Since coagulation pathways are induced uncontrollable, fibrinolysis system cannot balance, resulting in generation of fibrin which spread through blood circulation. Disseminated intravascular coagulation or DIC can cause obstruction of small blood vessels supporting tissues, resulting in ischemic or necrosis and functional failure, especially in kidney. Moreover, DIC binds to and activates platelets through thrombin receptor, which leads to induce the expression of receptors for fibrinogen, factor V, and factor VIII. The event causes thrombocytopenia and decreasing in plasma level of fibrinogen, factor V, and factor VIII, which then causes failure in hemostasis, leading to bleeding. Abnormal bleeding in HTR is termed consumptive coagulopathies. Moreover, activated factor XII blocks the kinin pathway, causes prolonged bradykinin, resulting in arterial blood vessel dilation, which leads to hypotension. Human errors involving blood samples and blood unit identification are the most common causes of mistransfusion and therefore acute hemolytic transfusion reaction. Reported estimates place risk of near miss at 1 in 1,000, wrong blood given at 1 in 15,000, and ABO incompatible transfusion at 1 in 40,000. When signs and symptoms are presented, transfusion should be immediately stopped. Remaining blood unit, together with segments and post-reaction blood samples, should be sent to laboratory for investigation. The first investigation is to check for identification errors such as patient HNOID, ward of admission, diagnosis, or type of blood component indicated in request form to rule out mistransfusion. Secondly, we should check for pink or red discoloration of serum sample for hemolysis. And lastly, perform direct antiglobulin test to confirm immune-mediated acute hemolytic transfusion reaction. What laboratory results indicate immune-mediated hemolytic transfusion reaction? The first set of results is hemolytic markers. Within the first hour of intravascular hemolysis, increase of free hemoglobin together with decrease in haptoglobin level will be presented, and hemoglobinuria can be observed. After 1 hour, hemoglobin will be carried to liver for metabolization, and by this process, bilirubin will be increased within 24 hours, with a peak at 5 to 7 hours after reaction, and bilirubinuria can be detected. LDH will be increased after any cell destruction, including red blood cells. Its level lasts for a longer period. However, only single LDH level is not good enough to indicate hemolytic transfusion reaction. To differentiate immune from non-immune mediated hemolysis, direct antiglobulin test is the best to be performed. The results should be positive with mixed field agglutination pattern, where the agglutinated red cells are antibody-sensitized donor cells, while free cells are of patients. Precaution in laboratory investigation for hemolytic transfusion reaction. Hemolysis may be non-immune mediated, resulting from other causes such as osmotic or mechanical hemolysis. So these causes should be first ruled out. More information about non-immune mediated hemolysis is in the next lecture. Free hemoglobin is the direct marker for neurohemolysis. To assay for free hemoglobin, blood sample should be collected within 1 hour after reaction. If it cannot be done, bilirubin will be the second next to determine, but blood sample is better collected within 5 to 7 hours after reaction, as it is the peak time of bilirubin level. As mentioned that hemoglobinuria may be observed, so urine analysis should be performed in parallel, and positive strip tests will be presented. Anyway, there are other causes for red blood cell residue in urine, resulting in positive urine strip test, which leads to misinvestigation. So these causes should be discussed and ruled out, such as stone in urine bladder or women with pre or post-menorrhea. Moreover, myoglobinuria may also show positive strip tests, so some pathologic status should be concerned, such as heavy exercise, women with cesarean section, surgeries, or other diseases with muscle lysis. Blood sample for direct antiglobulin test should be corrected in EDTA tube to prevent false positive from complement coating, especially when anti-human globulin polyspecific is used. In addition, according to the rapidly lysis of sensitized donor cells, blood samples should be corrected as quickly as possible to prevent false negative, which leads to misinvestigation. Additional laboratory investigation that may help in diagnosis and monitoring of medical treatment in HTR includes: for the IC, investigate for changes in plasma level of FDP and D-dimer. But more easily and faster is the presenting of schistocytes in blood smear. However, this can be applied only in patients with normal blood picture. Prophylactic markers for consumptive coagulopathies include decreasing in platelet count, which is the first marker observed after developing of DIC. Low plasma level of fibrinogen, factor V, and factor VIII. PT and APTT are used only to confirm consumptive coagulopathies and to be monitoring markers for treatment, not for prophylaxis. And for kidney function, urine output should be monitored carefully after supportive care to keep output over 100 ml per hour. In an early phase of HTR, detection of autoantibodies in patient serum may be failed because of low titers of antibodies. So, using of enhancement techniques may help. First, adjust volume of serum or concentration of red blood cells to increase serum to cell ratio from 40 to 1 to higher. Increase serum to cell ratio can be done by two ways: increase volume of serum or decrease red blood cell concentration. The precaution is that if increased serum volume is selected, more watching should be performed to remove out or non-specific proteins. And if decreased red blood cell concentration is chosen, agglutination should be observed carefully. Second, treat red blood cells with proteolytic enzymes. Papain, physin, or bromelain is often used to increase the expression of antigens of some blood groups, such as KITs, Lewis, I, P, and Rh. After treating, the reaction will be stronger. Third, use of LISS instead of normal saline. LISS is low ionic strength salt solution, which help reduce ionic strength of the buffer from 0.15 molar to about 0.078 molar. This can help antibody reach the antigen more faster. Using of LISS will reduce incubation time from 30 minutes to about 5 to 10 minutes. Fourth, use of PEG. PEG or polyethylene glycol is a polymer that absorbs water molecules. Adding of PEG in the reaction will decrease water molecules surrounding red blood cells, resulting in higher concentration of antibodies. And fifth, use of polybrine. Polybrine is positive molecules which can neutralize negative charges on the red blood cell membrane. This can decrease ionic crowds and make red blood cells move closer together. To prevent the transfusion reaction, two approaches that medical technologists should do. First, make a record of previous transfusion including results of all laboratory investigations, size, symptoms and severity of the reaction, medical treatments, and the best blood component suggested for his or her. Second, prepare the medical alert card for patient in order to alert the personal attending when visit the other hospital. What has to do in case of death related to blood transfusion? First, perform a record including records of ABO identical blood transfusion, record of cross-matching, and all laboratory records performed as requested during treatment or after death. Signs, symptoms, and patterns of reaction before death, and all medical treatments provided. Second, perform a report including a report to hospital director within 24 hours after death, and to FDA and Thai Red Cross within 7 days, together with all records and conclusion of the cause of death. In conclusion, it would say that blood transfusion can do no wrong, and prevention is the best management.